Hello, and welcome to another episode of No Notes, where the conversation is always a perfect 10 out of 10. This podcast is powered by Eleos, the most used and most loved AI platform in behavioral health, equipping more than 200 organizations and tens of thousands of providers with powerful automation tools that streamline documentation, simplify compliance, and surface deep care insights that drive better client outcomes. I'm your host, Dr. Denny Morrison, and for today's episode, we're taking a closer look at what's next for the behavioral health industry in the wake of the One Big Beautiful Bill Act, also known as H.R.1. We'll dig deep into how organizations can prepare for both the near-term shifts as well as the longer-term implications of this sweeping legislation. Joining me today are two experts from the National Council for Mental Wellbeing, Katherine Seibel, Federal Policy and Regulatory Strategist, and Peter Delia, Federal Policy and Advocacy Strategist. We'll talk about what we've learned since the bill's initial passage, what's coming down the pike over the next several years, and how leaders can start gathering data, engaging in advocacy, and building resilience before key provisions like Medicaid work requirements go into effect. So welcome, Katherine and Peter, and thank you so much for being here today.
Yeah, thank you so much for having us.
So let's start kind of with the basics. What do you guys do? You've got some very impressive titles, I have to say.
Well, I guess I'll go ahead and start. So as you said, Peter Delia, I'm Federal Policy and Advocacy Strategist for the National Council. Basically, my role is overseeing all of our federal legislative efforts, right? And all of the portfolios that fall within that. So things like substance use disorder, crisis care, workforce, and a number of other things like that.
And then on my end, I'm kind of Peter's regulatory counterpart. So I help manage all of our federal engagement on federal regulations, work with our members to make sure their perspectives and voices are uplifted in our regulatory engagement. And then I also lead our appropriations portfolio. So making sure that federal programs that impact the mental health and substance use space get funded.
Excellent. Well, I suspect this H.R.1 has kept you guys pretty busy lately.
It sure has.
I'd say that. Yeah, it's kind of been nonstop, really, even since the beginning of the year, not even since the passage of the bill.
Well, so what have we learned since this thing first came out? What's changed? As you know, we did an H.R.1 podcast not too long ago, and that the fact that we're having you folks in tells you something about the importance of this to our industry. But things continue to evolve with this bill. I mean, it's like crazy. So what's new with it?
Yeah, Denny, I think we've learned kind of a few things. When the bill first passed, we still had a lot of questions. And in some ways, there are still things that we don't know yet. But we do have just some answers on a couple of topics that folks were wondering about back in July when the bill first passed. One thing that was added kind of late in the process to the bill on the Senate side, which I'm sure most folks are probably familiar with by now, is the Rural Health Transformation Program, right? That's the $50 billion fund meant for rural clinics and providers. Initially, the bill gave kind of some fairly minimal guidance about criteria and timelines for applying. We just knew that awardees would be announced by the end of the year, right? So since then, CMS has released a NOFO, or a Notice of Funding Opportunity, and the application period for states just closed pretty recently on November 5th, I think almost 2 weeks ago now. CMS has said publicly since that time, since it closed, that every state in the country has applied for the program, and every state will receive a minimum of $200 million. That represents about half of the total available funding, so $25 billion, and then another $25 billion will be awarded by CMS based on the scoring methodology that's provided in that NOFO. And we were really happy to see eligible facility types listed in statute for the Rural Health Transformation Program include things like CCBHCs, right? Certified Community Behavioral Health Clinic, CMHCs, Community Mental Health Centers, and opioid treatment programs, OTPs. Seeing that kind of explicit inclusion of behavioral health facilities, that was something that we really were hoping for. We were really glad to see included and called out. So, the last thing to kind of find out as far as the Rural Health Fund goes is how much total funding will be awarded to each state, and then how individual states will divvy up that funding, right? And we'll get the answers to those questions by the end of this year and then into next year.
Do you anticipate that the states will make that determination about how that will be allocated, or is that going to be predetermined by the feds?
So that'll be determined by the states, right? So once they know their funding amount beyond that initial $25 billion, once they find out how much they're going to get from that second tranche, that second $25 billion, our understanding at least is that states will divide up how that funding will be distributed among providers and clinics in the state.
Excellent. Um, the provision that has funded this is rural health, but how ubiquitous will this be for the community behavioral health system? I mean, it sounds almost all of the well, not all. A lot of the centers do a lot of rural health, but will urban providers be able to tap into this as well?
Yeah, so it's kind of interesting the way the statute's worded is there's no specific prohibition on, let's say urban providers being funded. I think that, ultimately states will probably focus on rural providers and rural clinics. But there is nothing specific in the statute that says urban providers can't receive any of this funding.
One of the things I'm always interested in is, particularly for rural health, is getting them internet access and getting bandwidth. Is there any provisions that would include or exclude technology implications like that for rural, or even there's some urban places that don't have good access?
Yeah, so there's specific program criteria and objectives listed in the NOFO by CMS, right? And a few of them really do focus on technology. There's nothing specific, to my knowledge, in the criteria that says, if you build out broadband access, you'll get a higher score within CMS's scoring methodology. But I don't think it's specifically prohibited either. So I think if states can come up with proposals that fit within the general programming criteria listed by CMS, which, like I said, does include technology in a few different places, I think that could potentially include things like broadband access.
Yeah, so providers ought to be thinking and be in communication with their state associations as well as their local departments of mental health and Medicaid about this, I assume. Is that correct?
Yeah, that's absolutely correct, Denny. And, to that end, we've really tried to kind of facilitate those conversations among our members. We have state associations that are our members and then individual providers and clinics as well. Shortly after the Rural Health Transformation Program was announced and we got some information on it, we actually developed kind of a template letter for our members, both clinics and state associations, to use when engaging with state officials to kind of highlight different ways that the work that they are doing now or may do in the future align with those program objectives and criteria. And there is one of, I think, the 8 permissible funding uses that's specific to behavioral health. So that was good to see. And we kind of really focused on that in our template letters, but we've really been kind of encouraging those conversations to take place.
Is there data about this on the National Council website that people could go to if they wanted to find out more about this particular topic, especially the rural health aspects?
We are kind of developing a number of different resources for our members that has information on the program. Like I said, that template letter, that's publicly available to all of our members as well. And then CMS also has a website that's dedicated just to the program itself. And they've done a couple of webinars on their end that have some really good information as well. We've also done a webinar for our members that we've shared out. We have a slide deck and a webinar that we shared in conjunction with that template letter as well.
Great. Those will be great resources, I think, for our listeners. So, this is a short-term benefit, and but in the long term, to the extent that you can predict anything with this bill, in the long term, what should people be concerned about in terms of the long-term implications of this?
I think the long-term implications are still kind of coming into focus in a lot of ways because many of these changes to Medicaid are so seismic and big, right? One thing we're hearing from some of our members in conversations that they've had with state Medicaid officials is that the data systems and IT infrastructure that's currently in place in many states may need to be upgraded, in some cases pretty significantly. We've heard in some states the infrastructure hasn't been updated in like 3 decades.
Katherine, from your perspective, what is your view on this bill and what the implications are for providers right now?
Mm-hmm. Well, and I think probably folks are already very, very well aware of this, but Medicaid's one of the largest payers for mental health and substance use services. So I think the impacts across our field are going to be very widespread. And I think a really important point, and that is that these will be impacts that we'll see for years to come. The effective dates and implementation of the many provisions that we see in this bill take effect over time. And so we aren't seeing a lot of these changes happen right overnight, but we're going to see this over the next decade. And then especially when we look at the compounding impacts of these provisions taken together, I think we'll see quite a profound impact very broadly across the mental health and substance use space. And I think we'll also see variation across states. So as these changes come into effect, states are going to respond in different ways. States have different programs, and what that looks like in their varying context is going to be different. So I think we'll also see a bit of variety there over the years to come.
When we prepped for this, one of the things you mentioned, Catherine, was like the value of early data collection and kind of taking a proactive stance. Say more about that.
Yeah, definitely. So again, it just kind of underscores this point that these changes are coming into effect over years to come, and they're wide reaching. So to the extent that we can get a really good set of baseline data, that's going to set us up really well for having a really good empirical evaluation of what all of these policy changes mean over time. And so some of these data points that you might start considering setting up systems to be able to collect and evaluate if they're not already set up is looking at the amount of uncompensated care furnished. Has that gone up or down? Is the amount of people either turned away or waitlisted due to capacity? What trends are happening there? Has there been an impact on your workforce? So is there an increase in staff need, or have there been staff reductions that you've had to make in order to maintain operating based on the financial impacts of this bill? Another point to look at is the impact of patients. So have you seen an increased need in emergency care or higher levels of care that's been needed? Are there just general trends in patient acuity that you might be looking at over the next couple of years as we evaluate the ongoing implementation of these policy changes?
Emergency room admissions, things like that.
Mhm. Exactly.
Anything that would, the Medicaid cuts are going to be significant, and so that the community-based providers stand to have a double whammy hit, that the Medicaid funding will go down for their clientele, and then those same clients who are now uninsured will now seek unreimbursed, uncompensated care from the same mental health center. So it's a kind of a double hit for the providers, isn't it?
Yeah, and I think when you also consider how states will respond in varying ways and what they might how they might respond within their Medicaid programs and looking at optional services, especially when budgets become tighter over the next couple of years. And then I think as well on the patient side, some of these requirements will add some stress and anxiety, I could imagine. And so what might that do to a person going through the medical system and trying to
Like
make
the
sure
work requirements. Same.
exactly.
Yeah. Yeah.
But there are also some provided exemptions in the legislation. We can talk about that more too, and that's an area I think Peter alluded to earlier, where we don't have all the information we'd like to have yet, but we'll definitely be getting more guidance soon.
Well, I have to tell you that just between the time that we did the first podcast and this one, that rural health is actually one of the first bright spots that I think last time it was all doom and gloom and unsuredness. Unassuredness. We didn't know where this was going to go, because and I think Peter, you mentioned when we talked about this podcast about that a lot of these things aren't going to hit until 2027. So what do people do between now and then, and what do you think? What's the timeline for that for the things that are rolling out?
Yeah, so I think there are a few things folks need to be able to look out for. H.R.1 says that CMS should disseminate guidance on eligibility redeterminations. That's by statute. That has to happen by December 31st. And those changes themselves start January 1st, 2027. So what's changing with eligibility redeterminations, right? So right now, Medicaid eligibility is assessed every 12 months. But under H.R.1, that's going to move up to every 6 months, specifically for members of the Medicaid expansion population. Beyond that, there is an interim final rule on work requirements that's due June 1st, 2026. And that provision itself, again, takes effect January 1 of 2027. Also starting 2027, there are going to be new changes to retroactive coverage for all Medicaid enrollees. Although the way these changes are going to be impacting different states will vary a little bit among expansion states and non-expansion states. So with retroactive coverage, that retroactive coverage period will be shortened from 3 months to 1 month for Medicaid expansion enrollees, and then 2 months for non-expansion states, basically other enrollees.
But isn't it true that that a lot of Medicaid in expansion states have kind of chosen to not call it Medicaid expansion, but it is de facto Medicaid expansion? That some states that politically they don't want to call it that, but they actually are implementing Medicaid expansion, but calling it something different. Is that the case?
Yeah. So Georgia and Wisconsin are two examples of that, basically, right? They've done it through the 1115 waiver process. They've created these waivers that cover people from, I think, ages 19 to 64, right? And with a certain income level. And that's essentially Medicaid expansion by another name.
Are the states held accountable to meeting enrollment targets, like through their waivers, for example? Are they expected to hit certain enrollment numbers that are projected? And if they don't do so, is there some repercussion for that?
No, there's nothing really like that in the bill text to speak of. No, kind of the only thing that CMS has accounted for there that's kind of close to that is, if states are kind of trying to get programs for work requirements up and off the ground and they're struggling to do so, if they don't think they have, the IT infrastructure for it, they don't think they're going to be able to keep people enrolled on a consistent basis, there's an option within the bill for states to apply for a 2-year waiver with CMS, which would actually delay the implementation of work requirements until the end of 2028.
Yeah, just one other point to add to what Peter was saying there. There is also a provision in the bill text. Peter, keep me honest. It's about $200 million set aside to support states as well with community engagement requirements. And again, similar to the good faith waiver, we don't have additional information other than what's in the bill text right now. But that's definitely something we're keeping a close eye on.
Peter, can you talk a little bit about the connection between the provider tax reductions? What are the implications of all that? Because I personally don't really understand that.
Yeah. So just to level set a little bit for everyone first, what are provider taxes, right? Provider taxes are arrangements where a state taxes providers like hospitals and nursing homes and also managed care organizations to help fund the state's share of the Medicaid program, right? And states use that to claim a higher federal match from the government. So this is a really critical source of funding for many different states. 49 out of 50 states utilize some form of provider taxes. Alaska is the only one that doesn't. So H.R.1 kind of substantially limits provider tax arrangements used by states to help finance that state's share of Medicaid. And I think, it's kind of easy to see how something like work requirements or changes to eligibility redeterminations can lead to coverage losses, right? That's not a really hard connection to make. But when you reduce the total amount of Medicaid funding available in a state, when there's a smaller pool of money overall, that could really lead to workforce strain and reductions at community-based organizations that rely on it. I mean, a lot of these clinics have really pulled every lever available to them to pay competitive wages and retain clinicians and staff. They've used things like, loan forgiveness programs tied to rurality, incentives for remaining in a place for a period of time and practicing. So when you reduce those overall revenues, that I think is naturally going to trickle down to providers and leave them with fewer options to retain that workforce overall.
And I'm going to date myself here, but back when I ran a mental health center, we were first seeing that provider tax, although it wasn't called that, for Medicaid rehab option in Indiana, and that the mental health centers, to get it, we had to pony up the match. The state wouldn't pay it. There was some discussion back then that was illegal. The state itself had to pay the match in Medicaid. Is that changed, or was that never the case?
Ben, there's been a couple of different issues as far as the provider taxes go, right? I mean, the providers have always had to kind of pay the tax, and then they get reimbursed essentially through higher Medicaid rates paid by the state, right? There are different forms of the Medicaid tax that their legality has been challenged at various periods of times. They have to be uniformly distributed, right? So different providers have to be taxed at kind of the same rates or similar rates. There can't be disproportionate favorable treatment given to certain providers. That's one thing that has been the subject of some legal challenges and continues to.
And just to point out to what Peter just alluded to, we saw a proposed rule looking to address the provider tax loophole that Peter is talking about. That rule hasn't become finalized. It was very, very similar to what was provided in the legislation that got finalized through legislation.
So if I understand this correctly, then if they do decrease the provider tax, that means that the state would be on the hook for the match, and therefore, and most likely will not be able to meet it. So therefore, Medicaid benefits will drop. Is that kind of the stream of thought there?
Potentially, yeah. I mean, they will have to backfill that revenue one way or another, and states are kind of talking about different ways to do that. I think a number of states are kind of calling special sessions right now, in some cases just for that purpose, really. Yep. So, but yeah.
So what is your kind of, as you take the pulse kind of at the state level, what are the various states doing about this? You said some are calling special sessions, but kind of how are they responding to these federal initiatives?
Well, I think there's a number of different things that different states are working on. And The way states respond is going to vary based on things like, for example, with work requirements, there are exemptions in there for mental health and substance use, right? There's one for individuals with a disabling mental disorder and one for folks with substance use disorder. Because those definitions haven't really been fully fleshed out yet by CMS, states are talking about kind of taking different approaches to it, right? How they define some of these different words. So it's going to depend on what CMS does in the interim final rule on work requirements at least.
I also think that this is, I know this is kind of a chicken and the egg scenario because we need to see the federal guidance first, but also it's a great time to engage with your state policymakers. To Peter's point, we can, as stakeholders, you can kind of anticipate, okay, well, what's in the legislation? What are some of the challenges that we could project or are known challenges already in our field that we want our state agencies and lawmakers to be very well aware of, so that once we see the federal guidance get issued, we're able to respond quickly. State policymakers are already very well aware of the issues from your perspective serving mental health and substance use services.
What other things besides direct advocacy should people be doing, Katherine? What do you see them, like, are there partnerships, coalitions? Are there things that potentially people could be doing?
Definitely. And I think that because there is so much coming down the pipe, we could start to view this even as an opportunity if we wanted to take the more positive perspective on this, right? To your point, what are there partnerships that you need to warm up, perhaps? For example, your local law enforcement might be really interested in this and might need to have an understanding of what some of the impacts and implications might be. From a practice perspective, I think now really thinking about how you can be as streamlined and proactive in your processes as possible, so that once these changes come online, your organization's already ready and thinking about this. Some examples of that could be looking to plan an enrollee evaluation across all different eligibility pathways. So how could someone be eligible? What sort of processes does your organization have in place? Are you working with partners in the field in your local context to ensure that someone who is eligible does get that eligibility through the different pathways that exist? Now is another great time to be looking at your technology. We've been talking a lot about technology. Now's a great time to evaluate your existing technology, see what's working efficiently. What do you need to have in place to support some of these processes that you foresee wanting to have in place? And again, just looking at the cost you have in place where you can be efficient and looking to be as proactive as possible.
To that end, we did a blog on this topic, and from the organization's perspective as a former CEO, kind of what things would I be looking at? And one of those was, which is one of my favorite sayings, is the secret to success is figuring out what you're not going to do. And I think this is the time to say, do we really need to do that, still do that business? Is that still the business that we are in, given these changes? And I agree with you, though. I think there is opportunity here. It's hard to see when you're scared, but anytime you get challenged with a major strategic change like this, it's time to rethink kind of what direction your business is going in. And the folks who say, well, we'll keep doing what we've always done, that's not a good strategy going forward. But speaking of technology, what role do you think like AI can play in any of that technology? We talked about broadband, of course, and that kind of thing. But what about the AI technologies that you're aware of?
Yeah, definitely. I think AI technologies can be really useful in taking some of the burden off staff and looking to leverage existing data you already have. Peter already called this out, I think, but in that RHTP, the Rural Health Transformation Program, one allowed use of funds is looking at training and technical assistance around new technologies, which includes AI. And so again, that states will be taking different approaches, but that's something you might look to evaluate in your state's own application, and then look to see what happens once. I think at the end of this month, those applications will look to be approved. Is that right, Peter?
End of December, yeah.
Yep.
So, Peter, from your perspective, what other technologies, AI or others, should people be looking at?
Anywhere, when we talked about broadband access, we talked about AI, but anywhere that you can kind of look and say, okay, where can that technology help us with things like, verification of meeting work requirements, right? How can we help streamline eligibility redeterminations? How can we make that a smoother process? Anywhere that you can look to integrate technology. But CMS has kind of emphasized the use of AI and other just new technology in general across the board. And one thing that they've proposed, we don't have a ton of background on it yet, is an app to actually try and verify income for individuals to meet work requirements. And what that'll do is hopefully capture people who are doing, for example, gig economy work, right? Because traditional state IT infrastructure is not great at capturing that kind of thing. So we're waiting for some more details on that, but that is something that I know is in the works with CMS, right?
Yeah, the gig economy is a growing percentage of the employed population. When you guys think about this stuff kind of going forward, I think, you've really done a great job of kind of laying out the big picture, but, kind of in the immediate future, what are some of the, our listeners are wondering, what should I do now? What are the things that what steps could people take now to start getting ready for this? Katherine, you mentioned, certainly capturing the data and start measuring things. And I agree with that. What else could people be doing?
I think if you haven't already, really becoming familiar with the provisions that will be coming, what they mean and when they'll be coming online, the National Council will be putting out a journey map and timeline to help walk you through these provisions and the timeline. And I think spending a little bit of time getting familiar with that resource could be really helpful, because once you kind of map out what provisions are coming down the pike and when, you can spend a little bit of time outlining how you want your organization to respond. Taking that time to digest and plan out now can be really helpful.
Yeah, I mean, I think, kind of similar to what Catherine was saying, I think reassessing care pathways to reduce duplicative steps, administrative issues that really consume staff time, right? And just the other things we mentioned before, identifying essential services that have to be preserved to kind of ensure that continuity of care, and then pursuing any kind of available philanthropic or other partnerships that are really focused on behavioral health innovation and workforce resilience and technology, and addressing the types of issues that we've talked about.
Well, Peter, when we were prepping for this, you mentioned you used the term realistic readiness. Tell us what you meant by that.
Yeah, I know it's kind of a loaded phrase, right? But Danny, I think what that means is kind of preparing as though all of the statutory deadlines for implementation will be met as they're laid out in the bill. I think we really need to be careful not to assume that any of the Medicaid provisions are going to be delayed or outright repealed. We've talked to some folks in various spaces who believe almost as like a given, really, that there will be some kind of a delay, at least, of some of these things. But I think we have to realize that there's no like tangible reason to believe that'll be the case. I mean, even in places in the bill where there is a possibility of delay, like the good faith exemption for work requirements that I mentioned, even though that language is in the text, I don't know that we can assume CMS will grant those requests because there's no requirement that they do so. So I think, a good way to begin preparing is by prioritizing the provisions, like Catherine was saying, in the order that they'll occur, and identifying opportunities for best practices and stakeholder engagement.
Excellent. So we're about out of time here. Give me kind of the summary here. What's your one thing you want people to be sure and take away from this in the big picture?
Yeah, so I think, reviewing all the different provisions and their timeline for implementation, being focused on things as they come. As Catherine kind of mentioned, we'll be publishing a journey map pretty soon, right? You might want to spend some time with that resource and begin to outline how your organization would like to respond. But doing those things, again, having conversations with your state officials and with partners in your community, I think so those are some of the key things to focus on right now.
I 100% agree with Peter's points and would say the same. And I think I would also add, we're all in this together. These are big changes coming, and together as a field where we can take them on. And the National Council is here to serve as a resource. If you have questions, we're always happy to connect and support.
Great. Katherine Seibel, Peter Delia, thank you so much for being here today. We look forward and we'll be in touch with you. Look forward to more things from the National Council, but I certainly appreciate your leadership and guidance on this. This has been very helpful.
Well, thank you so much. Really appreciated the conversation.
Thank you, Denny. It's been great.
You bet.